Hi everyone, thank you for joining us today and welcome to our webinar, Mastering 3D Software for Endodontic Applications. My name is Nicole and I'm part of our customer success team here at Osteoid. Before we dive into today's webinar, let me share a bit about us here at Osteoid. We are a pioneering 3D imaging software company specializing in Invivo software, dental services, and cloud platforms. Founded in 2004 as Anatomage, we rebranded to Osteoid in 2020 to focus more on our dental clientele. Our Invivo products and services are the gold standard in 3D digital dentistry. Today, I am pleased to introduce Dr. William Scarfe, renowned oral and maxillofacial radiologist, author, and lecturer. Dr. Scarfe is a professor at the University of Louisville School of Dentistry and has a distinguished career in radiology and imaging sciences. He graduated from the University of Adelaide School of Dentistry in 1982 and earned a master's in oral and maxillofacial radiology from the University of Texas in San Antonio in 1992. Dr. Scarfe has been a faculty member of the University of Louisville since 1993. He has held several prestigious positions, including Treasurer and Editor of the American Academy of Oral and Maxillofacial Radiology and Vice President and North American Regional Director of the International Association of Dento-Maxillofacial Radiology. Currently, he is a Fellow of the International Team for Implantology and an Associate Editor for Oral Surgery, Oral Pathology, Oral Medicine, and Oral Radiology. He also serves on the editorial board of the Australian Dental Journal and reviews for over 30 journals. Dr. Scarfe is a diplomat and director of the American Board of Oral and Maxillofacial Radiology. He has extensively published on cone beam computed tomography and contributed to several textbooks including White and Farrow's Oral Radiology and 3D Imaging and Endodontics. He co-edited a textbook on CBCT with Dr. Christos Angelopoulos and frequently presents nationally and internationally. His research focuses on clinical applications of AI, tomosynthesis, panoramic, and CBCT imaging. Today's agenda will include the standard endodontic 3D image workup, common mistakes such as endodontic misdiagnosis and mismanagement, applied endodontic 3D imaging with Invivo's tools, and recognizing endodontic conditions like fractures and cervical resorption. Before we get started, there are a few housekeeping notes to mention. Everyone will be muted during today's session. If you have any questions, please write them down in the Q&A box below and we'll address them at the end. Any questions that we miss can be sent to info@osteoidinc.com. Now, without further delay, I will pass things on to Dr. Scarfe.
Nicole, thank you so very much for your very kind introductory remarks, and also thank you to Osteoid for the opportunity to present on a topic related to oral and maxillofacial radiology, and an area that I've been involved with since 2004 when we installed our first cone beam CT unit here at the University of Louisville School of Dentistry. Thank you very much also for the outline of what today's presentation is going to be like. And so I think it's important for us to realize that at the start that when we first were all introduced to cone beam CT, it is the Ferrari of oral and maxillofacial imaging. There's absolutely no doubt about that. But if you go to YouTube and look at people driving Ferraris, there's a mixed bag. And it's incredibly important to understand that access to an instrument is not necessarily related to competency in 3D imaging. Within the educational area of University of Louisville, we teach DMD level and postgraduate level principles of looking at the imaging and acquiring the imaging as well. And these now are separate courses within the curriculum. What I would like to do today is to try to introduce you to some basic principles of how to drive your imaging Ferrari, if you've got one, but also how to look at the images themselves. In the background of all of this, because I'm not just simply a radiologist, I'm also a clinician and work extensively with all the different units here at the University of Louisville, I'm very well aware that patients come in all different shapes and sizes, and their imaging is only one part of the whole diagnostic process. And although in certain occasions, particularly as we'll see here today in the examples that I provide, cone beam CT is an important piece to complete that picture, it's not the only piece. So background information, diagnosis, examination, and knowledge form the basis of any interpretation at all. I'm also going to be showing the application of Invivo today, and there is a learning curve with this, and all software indeed. We start from far left as children, as it were, until we get up and running with the software to be able to understand what we're looking at. But much of the process in between is fixed. In other words, it is a sequence of images. And although I'll be showing those sequences today, I don't think it's necessary in the long term for dentists themselves to do that, and others within the dental operating environment, such as dental assistants or dental technicians, can be trained to present the imaging to the dentist to minimize the time. But I do think it is very important to understand how we get these images and how to interact with the data. Let's start off with the concept that I've coined over a number of years, referred to as voxel vision. And cone beam CT data sets are actually a really cylinder of three-dimensional voxels in grayscale. And the images are generated from that. And the images, by default, are shown as a display in three secondary or perpendicular planes to what the area of acquisition is. And this is referred to as orthogonal projections. In medical imaging, orthogonality is important and the principal method by which images are reviewed. In dentistry, it's not the principal way in which we review images. We usually reorientate the data to the specific anatomic part that we're interested in. In today's presentation, that will be obviously the tooth. If this was temporomandibular joint, we would reorientate the cone beam data set to be perpendicular to the TMJ. So these secondary planar images, most of you would be recognized by now, where if we're looking at the skull or the patient from above, we would be looking at them in an axial plane. If we would be looking at them from the side or laterally, that would be referred to as the sagittal plane. And finally, from the front, that would be the coronal plane. However, if these are not exactly at right angles to the patient's profile, as shown here in this diagram, we often call this or refer to this as sagittal, transaxial, or paracoronal. We're absolutely, compared with our medical colleagues, inundated with dynamic digital light box arrangements, one of which is the Invivo software. Certainly, cone beam units themselves have proprietary, but being an agnostic software platform, Invivo provides a number of different tools that we're going to investigate today to be able to look at the voxels in their requirement. The basic background of looking at teeth and pathology and related to endodontics is that we must have a systematic approach. And this approach is the same no matter what type of pathology we're looking at. And there are four pillars to that approach. The first is reorientation of the data set. This is the primary importance, or we're going to introduce some interpretive errors. The second is, and comprises two components, is we need to correct the data. It is rare, excuse me, it is rare that cone beam in and of itself, when we press the button and visualize the image without correction, that the image has the adequate density as related to contrast and brightness, or the adequate image fidelity as regards to edge enhancement and reduced noise that we need. So we usually do need to correct this. Some machines are capable of using preferences to adjust this for particular types, and we use that quite extensively here. The final area is to reformat the data set according to what I would have referred to as task-specific imaging. And today that will be with regard to endodontics. So let's have a look, first of all, at some common errors that we've seen. My role at the University of Louisville is as the consultant specialist, as it were, and provider of images to a vast array of different specialties and within the dental clinics as well. We have a number of different cone beam units in satellite offices and also spread within our endodontics department, which are operated independently of radiology. So quite often, individuals who have taken these images will come to myself and my three colleagues, and they will say, well, what's wrong with this image? What did we do wrong? How can I diagnose, etc.? And so I would like to share with you today some common errors that occur frequently in the hands of general dental practitioners or in fact specialists that can lead to misdiagnosis and ultimately potentially mismanagement. So here's the first example, and this is two periapical images of a patient. This is actually from 2 weeks ago, a 72-year-old man who had number 3 extracted about 6 months ago, and at the same time they had a bone graft. We've got preoperative imaging on the left and postoperative imaging on the right, and we can see that there's been excellent consolidation of the bone graft, and there's an implant planned. But endodontics was involved because there are two conditions associated with the root canal filled tooth. The first one is probably the easiest to see, and that is that associated with the impacted third molar, there is a relative radiolucency associated with the apices of all of the three confluent apices of the mesiobuccal, distobuccal, and palatal root. And before implant was placed, we wanted to look at the prognosis of this particular tooth. An additional feature is on the right-hand side, on the mesiobuccal aspect of the root, you might see some notching at about the cervical area. And this was not present at the time at the time of the preoperative image where the first molar was positioned. So the concern was the radiolucency due to tooth number 1, or was it associated with root canal filled number 2? And is there root resorption on the mesiobuccal root of number 2? And this is this is the cone beam that was performed in a clinic at the University of Louisville. And we can see here we've adjusting the image now. We're moving from top to bottom, or axially, and you can look at the image on the top left-hand panel. And in this region where the root canal is, we can see a lot of blur and mistiness. We're looking now at the top lower left-hand panel, which is the axial view. And although we can make out the bone, the implant, the tooth itself, and the association of the radiolucency with the apices of the teeth is really difficult to determine. And this is very common. This image of cone beam CT is of poor quality, and it's related to motion artifact. It's not the machine, and it's not the settings. And the other problem with this is if we're trying to really assess the third molar and its potential in contributing to the periapical area, it doesn't fully include the third molar. So there are two common areas that we see: a lot of scans with motion artifact, and a lot of scans where there is inaccurate extension of the field of view over the region of interest. This is another example of a common error. This is a 58-year-old man, and we can see the sagittal imaging on the left-hand side, which has root canal performed, and we're missing part of the crown. And the plan here was to remove the crown and replace the crown. We can see that there is some idiopathic osteosclerosis on the distal aspect of tooth number 19, which is irrelevant in this case. But the consideration was that they're going to replace it. Now, the image on the right-hand side is a subsequent image post-operatively, you can see that the crowns are somewhat different. But before we do that, there was a concern from the cone beam on the left-hand side. Was there distal caries? Was there, in fact, a fracture, as we can see, which goes through the distal root? And is there any furcation involvement on number 18 before the crown is performed on that particular tooth? If we look on the right-hand side, as the movie will show us, this is 3 months after the image on the left-hand side. And there is a difference in the scanner that was used, but we can see very clearly here we've got external root resorption, a vertical defect on the right-hand side, and a very large furcation involvement associated with this tooth. And based upon the image on the left, they did proceed with the crown, as you can see here. There are ceramic type crowns associated with this tooth. And unfortunately, the prognosis of the tooth number 18, which has the large vertical defect, is extremely poor. So I see this a lot, that people will accept quality when they don't know what they can get out of their machine. This is the same patient, and I want to show you what the images look like when we do get a quality image. The image on the left, we can see not only the sagittal now, but we see the axial, and there's a lot of spray artifact associated with the axial image in the middle of the screen, slightly to the left. But if we look at the image on the right, which was actually taken with the newer model of the machine that we had installed here at the university, you can see very clearly that there is external root resorption and a large distal defect, most likely associated with a fracture of that root. And we can see also there's loss of lingual cortical plate, which also tends to suggest a fracture in this region. So it is important that we understand that there is some masking of effects by beam hardening, and we need to work on that error. And we'll talk about that slightly. Here's another one. The third common error is this is a periapical image of a 47-year-old woman who had pain in the mandibular right posterior region. And the concern here, you can see that there is composite resin on the occlusal aspect of number 30 and distal aspect, and composite on the mesial aspect of tooth number 31, and there seems to be a fracture of that composite. So the concern was that, in fact, this was tooth impaction and food impaction in between and approximately, which was causing some degree of concern. Now let's have a look at the apices of the tooth of number 30, and we can see here there's slight widening of the mesial root of number 30, but certainly the PDL space on the distal aspects of both roots on number 31 and the 30 are certainly within normal limits. We decided to take a cone beam CT scan here because this type of pain did not add up, as it were. The type of pain was not consistent with the type of area that we suspected, which was food impaction. And so here's the image, the cone beam CT image here, and we can see the sagittal on the top right. But if we look at the 3D, we can see very clearly that there is a very large unilocular, well-defined, almost cauliflower shape lesion associated with the mesial root. It's absolutely absent on the periapical image on the left-hand side. And this is ossifying fibroma in the tooth in the area where there was a partial resection of the alveolus in this region to remove that. And so this brings us to another common error, is that some people are reluctant to take cone beam CT imaging on patients where the periapical itself doesn't show much. So let's have a look at what these errors are coming from the trenches. The first one is incorrect acquisition protocols. In other words, although individuals are trying to save patients on dose, they are, particularly in endodontic situations, problematic. So we look at a standard acquisition on the left-hand side here, and the movie shows that we have 2 root canal filled teeth and a missing number 3, if we look at the axial image on the top right-hand side of that first panel, we can see a lot of star artifact or bleeding of the root filling into the both palatal and the buccal area. If we look at on the right-hand side, another image of a different area on a different patient, we can see that there's very little artifact associated on the axial image. The root canal filling material is clearly identified. There's very little beam hardening, which would be dark streaking, or scatter, which would be white streaking on that axial image. And the reason for that is shown in the legend on the lower right-hand side. This image has been taken at a higher kilovoltage. It's also a longer exposure, and which means it has many more frames or much more information, and it's also taken 360 degrees. So although the image on the right is approximately a third to almost twice as much dose as the image on the left, the clarity of the image, particularly in a small field of view, is much higher. The next area that I see is with incorrect acquisition is it is absolutely important that in endodontics we pick the smallest field of view available, except in one situation, and we'll demonstrate that in a moment. And the reason for that is cone beam CT units, if we increase the field of view to include either the maxilla and the mandible, or in fact just one jaw, because of the size of the data that's available, there's usually a resolution or a voxel size limit. We can't go as small as we like. So if we decrease the field of view, we can get the highest resolution available to us. So high resolution scans usually cannot be acquired with a full field of view. So to give you an example of this, then this is a particular patient who presented. In fact, they're a dental student, and they had another dental student take their bite wings, and they were concerned about a small region just below the distal cusp of tooth number 31, the mandibular second molar. And we can see there's a little circularity there. And they took a periapical, and that's on the lower part of this image, and that tended to sort of go away somewhat. But if we look at this and we took a cone beam, because there's another feature in the bite wing which you may or may not identify, and certainly when we see the cone beam in the retrospectroscope, as we call it, you can see it very clearly in the bite wing, not so much in the periapical. And here's the cone beam CT image. Please excuse it is actually flipped, so it looks like it's the left-hand side rather than the right. And what we can see very clearly on the most distal tooth is that, and then where you have it magnified, is that there's external root resorption on the distal aspect of that tooth. There's also, which is what we saw, a carious lesion immediately inferior to the enamel. We can see that on the cross-sectional image on the top left cone beam CT pane, but there is a very large area of external root resorption and widening of the distal aspect of the PDL associated with this tooth. Now, this is a small field of view. It's done at very high resolution, but we've seen on a number of occasions, if someone presents with external root resorption, it is often in other teeth, either adjacent to this area or even in the opposite arch. So what we did on this patient, because of our experience, we make an exception to small field of view when patients present. And in this particular case, here's the external root resorption, but we also performed a cone beam CT of the maxilla. And if you can see very clearly, I'm going to identify now another area of external root resorption in the maxilla. And here it is here. You can see it's at the cervical to mid-third of the root. And the axial image will, there it is there on the top left-hand side. The sagittal image shows it very closely. So we do have one exception to that small field of view, and that is if the patient presents or there is suspicion of external root resorption, we will take a field of view including both the maxillary and mandibular areas. The final thing is actually a technical issue where because motion can be important in covering or masking fine detail, many cone beam CT units do a 360-degree rotation around the patient. But it is possible, theoretically at least, to use half of that rotation to reconstruct the image. There's one particular unit which allows you to do that, and we've found that incredibly useful in patients who we look at the scan after they've left the building. And here's an example of a very typical motion artifact where there's like double imaging of the central incisors, lateral incisors. And with the data, we reconstructed it, and this is referred to as limited arc reconstruction, to be able to produce an image which is of adequate diagnostic quality. This is not a separate scan. This is the same scan, and we chose an area where there was no motion. The final part of the common area with respect to incorrect acquisition is it is absolutely important to use the highest resolution possible. Here is a sagittal image with a furcation involvement and an apical lesion on the mesial root. And this was rescanned. And this original one was at a 0.25 millimeter nominal voxel size. It was rescanned here, and we can see that the reason for this furcation involvement and its extension apically is related to a complete fracture or horizontal fracture of the root, which just happens to be at the level of that small post which is inserted into the mesial root. And so again, the highest resolution possible for endodontics, and our recommendation is that less than 0.125 millimeter, because the average width of the PDL space is approximately 0.2 millimeters. The second common error is that many practitioners will not adjust the image. So this is an image of impacted teeth where the raw data shows certainly the impaction, but if there is some attention to detail where the contrast and brightness is adjusted, and then finally some degree of edge enhancement is performed, then we can get a much better image from which to diagnose. So if we look at these three types of images after this is the original image on the top left, the adjusted image, which appears to be slightly darker on the right, and the sharpening filter on the top, on the lower right, then certainly it's far easier to identify root resorption or any other features related to the root of the tooth. Another thing that we have identified is a misdiagnosis related to the application of edge enhancement. Here we've got an external root resorption where there's a variable edge enhancement involved. In the Invivo software, there are three levels. There's no enhancement, a mild, and a moderate enhancement. In this particular issue, usually what occurs is if edge enhancement is involved or selected, and I do this routinely, I'll usually increase the thickness of the scan to reduce the effect or the banding effects around this tooth. And this banding effect, where we create a discrepancy between a high density area and a low density area, is called Überschwinger. So we will increase the thickness when we also apply the edge enhancement filter in any software. The third area is incorrect patient preparation related to detection of fractures and detection of cracks in teeth. This is a particular patient here, we can see that there's a post in the second premolar and the maxillary right area. A periapical image shows a large periapical radiolucency extending to the apical region of tooth number 4, but the suspicious tooth is obviously the tooth with the post and the previous root canal treatment, because there's no restoration at all in tooth number 4. So tooth number 5 is the concern. And so what we will often do is actually take 2 cone beam CT scans. We'll take one when we're looking at fractures, fracture detection or crack detection. We'll take one initially, and if we don't see the fracture, we'll use either bite sticks, or you can use a cotton roll, or you can use any other device like a tongue depressor, and have the patient bite on that during the scan. This is difficult with cone beam CT units that use an anterior bite block, because they innately separate the teeth. So in this particular case, we can see here the sagittal image on the left, and we can see very clearly the extension of that radiolucency to the apex, but we really can't see much associated at the apex of the post. If we look on the secondary image, this is taken same day, 5 minutes later, with the patient biting on a bite stick. We can see that there's actually separation of that root fragment, and also clear delineation of the vertical root fracture through here. So this is now our protocol, because fracture detection is quite difficult. Usually this is going to be uncomfortable for the patient, so they need to be warned that they're going to induce their pain such that we can see if there is a fracture evident. Another thing that we have discovered is that when we cone beam CT a complete area, there is some extension of metallic artifact, such as beam hardening and scatter artifact generated from the metal, inferior to where the crowns are. So often what we'll do is, instead of scanning the entire crown of the tooth, because in this particular case, we're not that interested in it, what we'll do is we'll adjust the field of view, as shown here on the lower left, such that only the roots are involved. And what this does is that it reduces the amount of noise for the image, and also minimizes the effect of beam hardening or scatter hardening associated with this tooth. The fourth common error is understanding the effects and how to mitigate against artifacts created from beam hardening, particularly in the area of diagnosis of fracture lines. And the image on the lower right here is a test image with a post in it, and there is a fracture in this central incisor, except because of the scatter, which is the white area, and because of the beam hardening, which is the star artifact, which is mostly dark, we really can't see much. And here's the same tooth with got a percher in it, and we can see another linearity through this tooth, which is not in a star-shaped pattern. It's slightly oblique to that, which is suggestive of a fracture. But finally, here is nothing in it at all, and we can see the fracture very clearly in the vertical root fracture. So it is important. Now, we can't, when we're looking for fractures in root canal filled teeth, usually take the root filling out. But there are some tips and tricks that you can abide by. The first one is to increase the thickness to differentiate a fracture from artifact. In this particular patient, we're looking at a symptomatic tooth, which is the maxillary left canine, tooth number 11. We can see that there's a large pneumatization of the sinuses bilaterally, but the PDL space associated with the tooth in this region looks relatively normal. Here's the cone beam CT of this particular area, and it's displayed at the native resolution of which it was acquired, which is 0.08 millimeters. It's the highest resolution. But again, if we look at most notably the axial image on the top left, we can see that there's scatter artifact, which is the white, and darken star artifacts, which are dark from beam hardening in this region. So what we have discovered, and much of this has come from a colleague of mine, Dr. Bruno Azevedo, is that here is an image on the left, cone beam CT image data, where there is suspicion. This is the same patient, a suspicion on the palatal aspect of this root, but we see a lot of dark line right adjacent both to the post and also adjacent to the root filling. So it's a bit hard to determine, whether this is artifact at the base of the post or not. So what you can do is you can increase the thickness of it. And as we scroll through here, we'll see that remember the artifact I mentioned before, Überschwinger? The Überschwinger artifact is diminished, but we can still see this horizontal line at the base of the post. And then finally, if we increase the thickness to a much wider area, this fracture remains. So what we have found is that to distinguish between artifact created from beam hardening and scatter, if we increase the thickness and go back down and up, meaning we increase the thickness and then decrease the thickness interactively, we can try to identify these features. Another way is the error is artifacts, as I mentioned initially in one of the common errors, was to reduce the motion artifact. This patient presented with strange dental caries, and 21-year-old male. And the periapical image shows something similar to what we saw originally. And the suspicion was external root resorption, not very clearly seen on the panoramic image on the left. But a cone beam CT was taken at an outside office and referred. That just happened to be on the same machine. And a consult was requested from me. And it's very difficult to identify specific details of this tooth. We can see that maybe the pulp palm is enlarged, but it's very difficult to see any precise details. So I suggested that the patient come in and we scan the patient. So same machine, different practice, but now we can see on the right-hand side, without any motion artifact, very clearly the extent of the external root resorption defect in all of the orthogonal views. Motion artifact comes obviously from patients moving, either shaking during or moving their jaws. These are the basis images here of cone beam CT. And you can see that the patient actually opened their mouth during the scan. And this creates a misregistration of images due to instability and creates double contours, as we can show here. Here are the original images of another patient scan. We can see double contouring and blur. And we can also correct these not only by ensuring that the patient is closed correctly, but there are some softwares that enable motion artifact reduction algorithms. And this is an example of one here, which is the same patient with application of this motion artifact reduction. Not all software has that available to it. Some of it now is artificial intelligence based. The fifth common error is that quite often practitioners will view images natively. In other words, here's an example of a patient who was scanned for a periapical radiolucency on tooth number 8. And the first thing that practitioners will do is create a panoramic. And the problem with that is if you look at the axial image on the top left, is that many of these cross-sectional images that we're seeing on the right are not exactly perpendicular to the tooth. And that results in what we would refer to as parallax error. So on all patients for root canal treatment, we will adjust all of the planes to be perpendicular. The first plane is usually the sagittal plane. We'll adjust the coronal plane such that the midline goes straight through the tooth, and then finally adjust it. And we can see here on tooth number 9 is actually worse than tooth number 8, with a external root resorption extending all the way down into the apical third of the root. So the first endospecific protocol is always reorient the plane to the tooth. The second is, although we take these images at very high resolutions, you can see here that the image, as we scroll through the image sagittally, is very noisy. And because we've applied the edge enhancement, there's this Überschwinge or banding effect adjacent to very high density. So I usually look at all endo cases using 1 millimeter sections here. It's a cleaner image, a clearer image, even though we have higher resolution, but it gives me some idea, and it's easier to look at and identify areas of further concern. The final thing is we have a myriad of different types of formats to look at cone beam CT. We've got multiplanar reformatting, abbreviated MPR. We have RaySum, we can make it look like an X-ray, and then we have volumetric rendering. And so we really have a toolbox of instruments, but we need to use the tools in a specific order. And there are some softwares in which, one of which we'll demonstrate today, which is the Invivo tool, which has very task-specific imaging for endodontics. And so for the remainder of this presentation, I'd like to demonstrate to you a number of cases using this tool. But first of all, we need to go through the tool, and what better way than to look at a patient image. Here's a 14-year-old girl with an infra-erupted and crowded number 9. They also have labial impactions of the canine, but the major concern, at least based from the panoramic, is that this tooth number 9 did not come into occlusion. So we took a cone beam CT scan, and we're going to apply the endo tab. And the first thing that we would always do is to isolate the tooth. And we isolate the tooth by drawing what's referred to as a bounding box. You can see here on the middle part of the screen. And then we adjust this bounding box to be perpendicular to the tooth in all dimensions. First in the sagittal, then in the coronal, and now, as you can see here, in the axial. We rotate it such that all of these cross sections line up perpendicularly, and then we'll apply it. The next component is we actually get a very small region of interest that we're interested in. And what we would like to do is remove the adjacent structures so we can see this tooth or this region very clearly. We use the sculpting tool to do that, and then we can concentrate on looking at this particular thing. We can look at it in slice view now, which is the third area. We can look at it in respect to the tooth tab. We can look at it with respect to the bone tab, which I particularly like. We can see here the very large defect on the mesial aspect of this tooth. We can also go through the tooth, and this is the endoscopy mode. And we can look at it, the endoscopy mode, looking at it through bone. And then finally, the idea would be to look at the axial and lateral, or referred to as radial images. So here we're looking at the axials and now the radials. So this is like looking at all this tooth as if it was sectioned multiply right through the middle of the tooth. And this gives us a clear representation of this particular tooth. The final area, which I believe that this is particularly useful in with this software, is the measurement tool. You can see here, you can click on two aspects of the tooth, usually done in the cross-sectional image, but now in 3D, we can adjust it to be perfect. And here we are, we're adjusting the length of it such that it follows the apex, adjust the pulp aspect of it. And so this tooth now is 22.05 millimeters. And we have found that incredibly useful for preliminary diagnosis of length of teeth, and also in surgery for apicoectomies. So that's the endo tab, the utilization of the endo tab. So let's have a look at it with respect to recognizing particular types of situations in endodontics. We'll look at external cervical resorption, and then we'll look at fractures, splits, vertical root fractures, and cracked teeth. And what better way than because our patients teach us everything we know. This is a 64-year-old female co-worker who I've known for 25 years. And her husband is a dentist, and she had a crown loose in the mandibular left posterior region. The original bite wing was provided to me and, viewed by the husband, who didn't see anything, and subsequently was provided to me. And based upon this and also this image, I thought we needed a cone beam CT because I can actually see something associated with the distal aspect of the root of tooth number 18. So again, we're going to go through this particular case using the endo tab mode, and we identify the tooth once again. We change the bounding box. We will then adjust the axes of the bounding box such that it's absolutely perpendicular to the tooth. And then sculpt the three-dimensional image by removing extraneous areas, which may be mesial or distal, or even we can remove a labial, or in this particular case, other areas of bone. But I find this incredibly useful to demonstrate to patients. So here we are removing extraneous material, including the occlusal aspect. Now we're going to remove the labial and palatal aspect of the bone such that we can demonstrate the defect. And once again, this is external root resorption, which is incredibly severe. You can see it's gone right through the pulp and involves the root of the tooth. So that took less than a minute and a half to do. And we're looking at now the axial image to confirm our impression in the three-dimensional image. We can identify the extent of the external root resorption. So external root resorption is a difficult management area, but sometimes the diagnosis is also quite difficult. I think it's important that we understand, what the classification system of this is, such that we can lead ourselves to a prognosis. And here's the European Society of Endodontics figure, classifying and providing examples of internal root resorption, which might be surface or tunneling resorption, inflammatory internal root resorption, or replacement resorption. And from external root resorption, we have surface resorption, which is quite often associated with orthodontics, cervical, external cervical resorption, inflammatory replacement resorption, and transient apical breakdown. So the previous case obviously demonstrated a case of external root resorption. So if we look at this more in detail, and I think this is important because it leads us to prognosis. And again, there is a classification system for external root resorption according to the location, the circumferential spread, and the proximity to the root. We can look at it at the CEJ, extending into the coronal third, or below the crest of the bone and into the apical third. Circumferentially, we can look at it in quadrants of 90 degrees, 90 degrees, 90 to 180, more than 180, and more than 270, and proximity to the pulp. So let's have a look at a case here to apply this. This is a 16-year-old boy. Once again, I get a lot of referrals from general dental practitioners, and this is the father of this patient as well. And so they're concerned about an incidental, painless, unusual radiolucency on 31, which is actually within the tooth. On the panoramic, it's quite difficult to determine what's happening. So if we take the bite wing, we can see again that there is something associated with the pulp, pulp size. If we look at the upper left, the bite wing is unusual compared with the opposite side. Periapical image really doesn't help us. But if we look at this particular patient, we opted in this particular patient because it's an exception to the rule. We've got a suspicious external root resorption that we can see here. We need to identify the tooth. We certainly can see it on the sagittal image. And on the 3D image using the EndoTab mode, we can also now identify that there is external root resorption on the mesial aspect of tooth number 30. So there are actually two teeth involved. Here we go through the axial images through our protocol using the EndoTab. Here is the mesial root of number 30 and also number 31. Now, remember what I mentioned earlier on is that with these particular cases, we will always investigate the entire mandibular arch here and the maxillary arch. So here are our defined external root resorption areas. And if we go into the maxilla, we'll find another area on the opposite canine. So applying the EndoTab, we can quantify it and classify it. And what are we going to do? So based upon the classification, we've got two conditions here. The first one is the one that we identified initially. And if we use Patel's or the European Society of Endodontics, it's a 3CP, and this tooth is going to be extracted. The concern at the moment is to allow the third molar to erupt, so we're using it as a space maintainer. We've also found another external root resorption on tooth number 30. This would be classified as a 2AD because it's not extended to the pulp yet. It's close to, but not there. And we've got a third area on this particular tooth, which is number 11, and that's classified as a 2AP, and that's going to undergo periodic assessment by cone beam CT. Here's the third patient. We can see here that they've presented actually with a maxillary left quadrant sensitivity to pressure. There's minimal restorations on this 52-year-old woman who's actually referred from a T&J specialist because of the pain to rule out any other concern. And cone beam CT was performed because there was suspicion of a crack or fracture in the restored tooth. So again, we're going to use the bounding box, adjust the bounding box. In this case, I'm going to include multiple teeth because of the vagueness of the pain. We adjust it. We're going to create the visualization and sculpt it such that we can remove some of these aspects to be able to look at the idea in 3D. And so if we spin this 3D around, we can immediately see on the palatal aspect of the first premolar what looks like to be a split of the palatal cusp all the way down. So we can then verify this and verify the extension of it using the residual components of the endo bounding box. The American Association of Endodontists classify this according to whether the tooth has a cusp fracture, which is the diagnosis in the previous case, a cracked tooth, a split tooth, or in the case of root canal treated teeth, a vertical root fracture. So the final case before we end is actually a colleague who presented and referred from a general practitioner with chronic, approximately 6 to 9 month intermittent pain in the lower left posterior. And there are obviously multiple full coverage restorations in all quadrants. And the panoramic was not significant, and the periapical was not significant at all. There is hardly any difference. The only radiologic difference, even as a radiologist, that I can see is that there is an absence of the lamina dura on the root canal filled tooth, but the PDL space is intact. This particular patient, even though a colleague was very resistant to having cone beam CT scan, and I indicated that I think we can get some information from this because of this difference, this even subtle difference. So we perform this cone beam CT scan here, and using the endo tab mode once again, we isolate the tooth. We adjust the region of interest such that everything is perpendicular, such that all of our slices, when we view them, are perpendicular. And then we can apply the volume of interest and look at it both in volumetric rendering, which doesn't show anything in particular. Again, we can look at it in the solid rendering, and then finally look at it in axial. And what it shows very clearly now is that there is a J-shaped lesion extending all the way down, and it's a tunneling lesion. And the reason we don't see it on the periapical is that if you look very closely on the top left-hand side image, that tooth is not at right angles, and that J-shaped lesion is covered by the mesial aspect of the root. So not only is it a J-shaped lesion, but there's also furcation involvement. And if you very carefully identify, change, and dynamically view, we're incredibly suspicious of a fracture. And in this particular case, I'm showing increasing different applications of thickness, of the different levels of edge enhancement. We can see what seems to be a fracture of that mesial root. Well, the tooth was extracted and confirms our diagnosis. So using this particular modality, cone beam CT, high resolution, small field of view, and using the appropriate imaging tools systematically has helped me enormously in the last 10 to 15 years get the maximum out of cone beam CT. So in this particular case, there were some features which are typical of a root fracture, but certainly the PDL space tunneling before it extends both labially is different. The furcation involvement, there's a consistent delineation of a linear radiolucency. And on the labial, and this was a mesial fracture, quite often there's a characteristic presentation of cervical bone intact, no bone about mid-root level, and bone in the apical level. These and more tricks up your sleeve are not that are readily available, I should say, in various publications. And we can see the position statement. I have a chapter in the 3D imaging and endodontics book by Fayed. The cracked teeth and vertical fractures is easily downloadable. And there are two other excellent books that I will refer you to be able to pick up on these things. Once again, thank you to Osteoid for the opportunity, and thank you very much, Nicole, for hosting this today. And I'd be more than happy to answer any questions.
Awesome. Thank you so much, Dr. Scarfe. Let's take a look at some of the questions that have come in. One participant asks, can you explain how motion artifact is identified in a CBCT image? How
Certainly.
do you, sorry, there's two parts. Do you want to answer that one?
Yeah, no. Let's have the second part. It might follow on.
How do you review a scan and recognize that the reduced image quality is due to motion and not metal artifact?
Yes. Motion artifact is fairly characteristic, usually somewhere through the scan. And if there is a scan of both the left and the right side, sometimes there'll be motion on the right, but not necessarily on the left. The patient will move on the right side. It's a little bit like panoramic. They can move one side and you'll see it on one side. So the hallmark is double contouring, which is it's like it's just slightly different of the cortical bone. The other part is I look very carefully at the enamel and the enamel dentin junction in the sagittal image. And if that's not clear to me, then I think that there's some blur. So they're the two areas I'd look. I look at the cortical plate, usually labial or buccal cortical plate, to see if there's double contouring. And then I would also look at the interface between the enamel and dentin in an unrestored tooth, if there is one available, to see if that's very clear.
Okay. Awesome. Another participant asks, are you worried about dose when taking scans?
We abide at the University of Louisville by the AAE recommendations, and within the AAE, there are certainly recommendations about when to take a scan. If there's concerns about anatomy, if there's concerns about fracture, if there's concerns that the regular 2D imaging can't answer. I have changed my position over the last 10 years, and I'm an advocate for the use of cone beam CT on any clinical situation which just doesn't add up. We've had too many instances where we've tried to use periapical imaging to identify something that's in 3D. And I've provided you with a couple of images, particularly that very last image. There was no indication at all that that was a vertical fracture from regular imaging, just none at all. But the pain and symptomatology just suggested vertical fracture. So I would go straight into that. I also indicated that we use the highest possible exposure. And the reason for that is we tried for probably a couple of years to use the manufacturer recommended exposure guidelines. And the problem with that, particularly if there's metal, if there's a post, if there's GP, is that you need more photons to be able to mitigate against the beam hardening artifact, which is your foe in trying to interpret these things. And the only way to do that is to increase the dose. So we've been down the road of taking, particularly on patients with multiple adjacent endodontically filled teeth, using manufacturers' recommendations only to say, well, I can't see anything, so we better increase the dose. So now we use the highest dose that's available to it. And there's plenty of data out there of which I've contributed a lot related to dose, but I am confident with the field of view. If you have made a decision that you're going to use cone beam CT, then do it, and do it only once, rather than cut yourself short in your diagnostic ability of the machine. Then go ahead and use the endo mode, use all the basis images, use a higher kilovoltage, and we've been successful in identifying these things because of that protocol that we use now.
Okay. Thank you for that. Another question is, do you have a recommendation for the best CBCT machine for endodontics?
Yes, we have a number of cone beam CT units at the School of Dentistry. Obviously, we don't have all 64 or now I think 75 different varieties. We have a lot of experience with the Carestream, with Marita, with Action, and all of those units have capability of looking at images and producing small field of view with high resolution, adequate for the purpose of endodontics. I think any of the units at all now are like that. There's quite a bit of preference to using different types of software. And the different features. Once again, I demonstrated today the use of or the systematic use of the Invivo Endo tab, which I find very useful because I can teach someone to do that. I don't do those manipulations all the time, but I could teach someone if I was in a busy practice to set it up for me to be able to do that. Certainly the principles that I've mentioned, which is reorientating, applying edge enhancement, increasing thickness to reduce noise, and also the Uberschwinger artifact, because that's what you get with the edge enhancement. All those capabilities are available on proprietary, but the one thing I really do like with the EndoView is that measurement tool. I mean, that really helps with surgical endodontics and also establishing length parameters for it. All of the machines out there, if they have a endo mode or a high resolution mode, are adequate. Even the large field of view units, which are sold for maxillofacial, now either have built into them a small endodontic, small region of interest, or are upgradable to that. So I do have a personal preference because obviously I have a limitation. It's the unit that we use all the time, which is the Merida unit. But as I said, I do have experience and equal experience with Carestream, which is excellent unit, Action, excellent unit. But as for the other units which are on the market, I don't have personal use of that, so I can't attest to how they work or how they're done.
Okay. Thank you. Another question, when using highest KV to get the best quality, what about adjusting?
Yes, you can adjust the MA down. This is a radiologist question, or a budding radiologist question, because that's actually in the chapter that I wrote in the book that I suggested as a reference at the end. You can adjust the milliamperage down to reduce the dose and get an adequate contrast for that, and that would be a possibility to do that. There are suggestions on how to do that in that book chapter. But yes, that's one way of reducing it. Milliamperage is a very small change in kilovoltage, leads actually to a large change in dose, and whereas a change in milliamperage, if you go from 8 milliamps to 10 milliamps to 8 milliamps, is a 20% difference. So you can adjust for dose using milliamperage. And because we have different users here at the school, as I said, we have different units in 4 different satellite offices. We have 6 units in our department and 3 others that are available to us. We have to be fairly agnostic in the description that we give to individuals, because usually what will come back is, oh, I use the big KV, but I halve the milliamperage, and I'm there. No, you did too much. You can reduce it by 20%. How much is 20%? So you get into these types of situations. But yes, if you want to finesse your own unit, certainly you can do that using milliamperage, which does decrease dose.
Last question, and then we'll wrap up. What new resources are out there that can help guide someone on introducing the use of 3D imaging?
Yes, I think I provided some resources at the end, which are literature. Certainly, the American Association of Endodontists, if you're a member of that, or can become an associate member of that, that's an excellent resource. They are a wonderful group, and also incredibly knowledgeable, because like a microscope, almost every endodontist now, if they don't, they wish they did have a cone beam CT unit. It's absolutely indispensable to an endodontist practice now. And so they are becoming experts in that area as well. So they put on courses at their annual meeting. They also have online events you can go to. The American Academy of Oral and Maxillofacial Radiology have a meeting that's coming up. It happens to be in Hawaii. I would always suggest going to a meeting and where there is some form of hands-on component. And even though it may not be the software that you're used to, it does give you guidance and principles. And the thing that being in person does give you is a contact. You get to meet people who are doing this all the time, and you can reach out to them. We're always being contacted by individuals who I've met at conferences and presentations saying, well, I've got this unit and I'm doing this, and I can't seem to get the same results you are. So I think that is important as well. Today, what we've done in an hour is giving you a basic paint by numbers approach to doing it. the way I showed you how to do these things comes from hours and hours of using it and applying it for the benefit of individual patients. That very last patient, I must have spent an hour and a half on that, trying to identify all those features. And once I did, I said, oh, then I need to do this on the next patient, etc. So you have to invest time and effort into it. It's not, as I said at the start, the learning curve is pretty steep, but once you get at the plateau of the learning curve, you can do these things fairly routinely if you have a methodology to it. So I do advocate reading bona fide literature, certainly from the organizations that I mentioned before. I also advocate, attending these meetings as well, which are endodontically specific. And there are a number of individuals and colleagues and friends of mine in certain areas that present online as well. Certainly, Bill Nadara up in Chicago, who I'm aware of, produces some materials. Also, the author of the two books of the book that I'm a part of, they also do presentations. So they are experts in their fields in the application of radiology to endodontics, and I would go to any of those presentations.
Great. Okay. So one more question, and then I promise. You spoke about half reconstruction in case of patient movement.
Mm-hmm.
Which software gives that functionality?
Yeah, it comes with a particular unit, and it is the J Merida unit. It is the X800 unit. And that's one of the reasons I indicated to you before. I do have a personal preference, and it's because of that. It's very specific to that particular unit, but it has been incredibly valuable to be able to reconstruct the images after the patient has left, or if they've moved. And you can reconstruct it and recover the area that they haven't moved. That's what you're trying to do. You're using the data in the region that they haven't moved. To my knowledge at the moment, and that's a physical reconstruction. You're just using selected data. What is most likely coming down will be artificial motion reduction artifact, and probably associated with artificial intelligence. I don't know specifically of any vendors that have that at the moment, but certainly it's been worked on, as is metallic artifact reduction, artificial intelligence algorithms. So my advice would be, if you're not in the market for a new cone beam, stay tuned, because artificial intelligence is changing our world, and it will certainly do that in the visualization of cone beam CT data.
Thank you so much, Dr. Scarfe, and thank you everyone for joining us today. We look forward to seeing everyone in our next webinar in August. We will send a follow-up email that includes a link to this webinar's recording. For newcomers, we have a special promotional offering that will be emailed to you as well in the next few days. And that's it. So from all of us at Osteoid, have a great day and a wonderful weekend. Thank you again, Dr. Scarfe. It was a pleasure.
Thank you very much. Thank you, everyone, for attending today.